Manoj Chandra Mathur. He's been talking about post-cataract surgery, ocular hypertension and glaucoma. We all know Dr. Mathur as a very, very renowned glaucoma surgeon and a very conscientious, hard worker constantly. Thank you.
Thank you, Dr. Kirti. Like I shall be speaking about the management of post-cataract surgery, ocular hypertension, or glaucoma. So we know that fluctuations in IOP after cataract surgery are not uncommon. Yeah. Okay. But needs a detailed and meticulous examination to find out the cause so that if timely addressed can help us achieve better visual outcome. So, the pre-existing glaucoma patients are more prone for IOP spikes. Complicated cases with excessive tissue handling and prolonged surgical time can be one of the reasons for post-op ocular hypertension, and also intra-op complications like PCR, etc. So in these relative risk factors, there can be a problem. So this post-operative timing, the causes of IOP rise can be ranging from days to even years. What are the possibilities? Steroid responders, there may be an increase in intraocular pressure, release of iris pigment and inflammation, retained viscoelastic. In the early postoperative period, there may be a problem. Sulcus placement of single piece IOL, watertight wound closure, and retained intraocular debris. So, first, in the early post-op period, IOP can rise in a few hours after routine cataract surgery, generally returns to normal in 1 to 3 days. IOP less than 30 millimeters with non-glaucomatous optic disc and a deep AC should not be a problem. What are the causes? As we enumerated earlier, influence of viscoelastic substances, inflammation and hemorrhage, AC IOL and iris fixated IOLs, vitreous in AC, pupillary block may be broken by a mydriatic or may need an iridotomy. Peripheral anterior synechia or trabecular damage may be the cause. Flat AC should be corrected suitably, and distortion of the AC angle. A tight corneoscleral suture or edema of the deep corneal stroma. Postoperative ocular hypertension can be due to inflammation that is frank subclinical, seen only in the operated eye. But steroid induction, basically the point of differentiation between post-operative ocular hypertension because of subclinical inflammation is generally uniocular, whereas steroid-induced, generally it is binocular. How do you manage? Post-op use of oral acetazolamide and topical carbonic anhydrase inhibitors are useful. Generally, substituting brimonidine with dorzolamide, brinzolamide can be useful. This is my practical experience. Like brimonidine, it is known to more prone to precipitate allergy and some sort of increased inflammation compared to brinzolamide and dorsal carbonic anhydrase inhibitors. Steroid use also can be tapered and switched to a safer steroid like fluormetholone. I use fluormetholone or NSAIDs and stop prednisolone acetate in cases of steroid induction or generally post-operative ocular hypertension. Eyes with pre-existing glaucoma, there may be a further nerve damage with transient IOP elevation, and tight wound closure may be responsible in these cases. AION may occur in eyes with vulnerable ocular nerve head circulation. The management involves post-operative use of oral acetazolamide, and prostaglandin and PG analog should never be used for the first 3 to 4 weeks. Then comes the malignant or the ciliary block glaucoma. Shallowing or flattening of the central and peripheral anterior chamber caused due to misdirection of aqueous. It is aggravated by the use of miotics, and generally there is a relief with cycloplegics. The possibilities: there can be a peripheral pooling of the aqueous, there can be a ciliovitreal or a ciliolenticular block, there can be slackness of low lens zonules and anterior hyaloid obstruction. How do we manage malignant and ciliary block glaucoma? Cycloplegics may help by breaking the ciliary shock, by contracting the ciliary body which pulls the lens back, hyperosmotics to shrink the vitreous, and aqueous suppressants. Surgical by lasers, YAG laser posterior capsulotomy and disruption of anterior hyaloid may be useful, and prophylactic YAG laser iridotomy for the contralateral eye may be helpful. Medical treatment involves carbonic anhydrase inhibitors, beta blockers, alpha-2 agonists, and myotics can be effective too in this situation. Laser trabeculoplasty for cases without PAS, surgical intervention for cases with uncontrolled IOP or maximum medical therapy, trabeculectomy with antimetabolite, glaucoma deranged device if superior conjunctiva is scarred, and transcleral CPC in patients with poor visual potential. So I'd like to conclude my talk by presenting you 3 scenarios. Case number 1, a 54-year-old female with a near total cupping, 0.9 cup in both the eyes, underwent a combined surgery. Preoperative intraocular pressure was 15 in the right eye and 11 in the left eye with 3 AGMs. Uneventful surgery with time of presentation 1 week post-op with IOP of 38 and in the right eye and 25 in the left eye. Patient was switched to fluorometholone with fast tapering, and then the second week IOP reduced to 20 and 15. A well-functioning bleb cause can be a steroid responder. Case number 2 underwent combined surgery, preoperative status poorly dilating pupils with NS3, uneventful surgery with use of pupil expanders, and then the time of presentation was 1 week postoperative, intraocular pressure was 28. The cause was detected to be retained cortical matter due to poorly dilating pupil. This was the cause. Case number 3, disc was within normal limits, time of presentation was 3 months. Delayed post-op ocular hypertension after cataract surgery, the pressures were raised up to 40, was put on conservative therapy, and then IOP at present was 12, came down to 12. The cause of it was the IOL in the sulcus. So these are the situations, and these are the things like how you possibilities and management for post-cataract surgery, ocular hypertension, and glaucoma. Thank you very much.